Good morning. In continuation with the previous lectures, today I will be talking about the investigative methods that are used for diagnosing or rather investigating oral cancer. The contents of my lecture includes an introduction, clinical examination, the importance of it, the various imaging modalities that can be used such as plain radiography and advanced modalities, vital staining, exfoliative cytology, brush biopsy, tissue biopsy, advanced modalities such as Viscilite and Whalescope, and finally the conclusion. So as an introduction, all of you would already have been familiarized by now that oral cancer is the sixth most common cancer worldwide. And despite the technological advancements in the treatment modalities in various aspects, the mortality and the morbidity of patients reporting with oral cancer still haven't reduced. And one of the two major reasons that have been found out among various studies is the delayed reporting by the patient as well as the delayed diagnosis or referral to a specialty center by a healthcare provider. So we being dentists should be absolutely thorough how to investigate or at least know the early signs and symptoms so as we can refer them to the necessary specialty centers where they can further undergo investigations and treatment. So it all begins not just with the clinical examination. In fact, it begins right from your history taking. That is, a very thorough history should be taken regarding the habits of the patient, about any signs and symptoms which the patients would have already noticed, or any other difficulties the patients would have overlooked it rather as a part of the ongoing chief complaint of some other finding like dental caries or something. But we, with our knowledge, we are supposed to be overlooking all that and actually close him into the diagnosis or at least into a suspicion of the diagnosis of oral cancer. And once your history taking is completely done and you have closed all the areas that has to be ticked off, you next have to examine the intraoral cavity thoroughly for any sort of suspicious red or white lesions. And when you examine these, if you're not able to find any suspicious lesions, at least eliminate any etiology that you can find in the patient's mouth that could actually make the patient prone to developing oral cancer, such as sharp teeth margins, ill-fitting dentures, overhanging restorations, and in case the patient reports of having a deleterious habit in their personal history, kindly advise them, refer them, or do the necessary tobacco cessation of the patient. Also, in case if you see any suspicious red or white lesions in the patient's mouth, always kindly take off a photograph and review the patient after 2 weeks, provided you have put the patient on an oral therapy of antioxidants, and see if the lesion is progressing or not. Depending upon that, you can actually decide whether to go in for further investigation or not. Now, when you are examining the oral cavity, what all are the things that you have to look for? You have to look at the extent of the lesion or the swelling. You should check for the margin characteristics of the ulcer, because few margins are a telltale sign of oral cancer. Okay, presence and absence of induration, which is again a pathognomic sign of malignancy around the lesion or on the lesion. Involvement of the overlying skin or mucosa. Trismus, which is indicative of deeper penetration by the pathology. Radiating pain to the ear, which actually indicates the nerve has also been involved. And also foul smell reported by the patient or noticed by the dentist. Other than that, you should also check for loss of function and mobility of the tongue. Diplopia of the eye on the affected side, which could be because of any pathology which has been extending superiorly into and started to involve the orbit. You may never know. And also any paresthesia or anesthesia of any nerve in the vicinity of the pathology that has been suspected, any discharge from the nose, any persistent postnasal drip, and slurred speech or excessive salivation. All these should be thoroughly examined for and correctly noted. Now, once you have gone in, once you're suspecting that it could be, or you find any lesion that is actually indicative of undergoing further investigation, kindly decide on what investigations is ideal for that particular lesion, depending upon the various modalities that I'll be talking about in the coming slides. So the diagnosis or the investigation of oral cancer can be done under very large, broad categories such as imaging modalities, where you have got plain radiographs, CT, MRI, ultrasonography, etc. You have vital staining, you have got exfoliative cytology, you have got brush biopsy, as well as you have got tissue biopsy. So depending upon what lesion that you're suspecting or what is the site and the size and the various characteristics that you've already learned about, you can actually advise the patient for the necessary investigation. So there are a few other newer diagnostic tools such as your Whale scope, Visilight plus Raman spectroscopy, high performance laser spectroscopy, laser induced fluorescence, which is in short HPLC LIF. These are all the newer diagnostic tools where you need you will need a kit or that instrument for it. However, even your conventional tools are more than enough for you to actually come to a conclusive diagnosis. So moving on to the imaging modalities. Imaging modalities should always be the first line of investigation because it is one of the most easily accessible modality for investigation and which is painless and it is bloodless also. So kindly always keep in mind, you should always start with a plain radiographic examination before you advise a patient for a CT, PET CT or anything. Kindly go off for confirming at least your suspicion on a plain radiograph such as your OPG, occlusal radiograph, intraoral periapical radiographs, etc. Now, among these, an extraoral technique of paranasal sinus view is actually good in assessing the extent of any bone involvement in the maxillary sinus region. Now, OPGs are indicated when you want to examine the maxilla, mandible, maxillary sinus, nasal cavity, and the floor of the orbit in a single radiograph. You can assess the pathology, the extent of pathology in all these structures, whether there is any spread of it. But however, for finer details, it is always an IOPAR, that is an intraoral periapical radiograph that is indicated, because you will be able to clearly differentiate any subtle bone invasion, bony trabecular architecture, as well as any destruction of the lamina dura around the affected teeth. Occlusal radiographs will give you an idea of the destruction of the bone, especially in your anterior portion of your jaws, because it gives you a labiolingual or a buccolingual extension. Now, these are all the 2D imaging modalities, and in all these 2D imaging modalities, there are a few typical radiographic features which is kind of pathognomic for oral cancer. The first being the moth-eaten appearance. It basically is nothing but an ill-defined destruction of the bone with ragged borders. You can also see thinning of the cortical plates, especially if the malignancy has spread quite much, leading to thinning of the cortical plates, which can also lead to pathological fracture, as you can see in this image over here. The next is also extensive lesions not only can cause thinning of the cortical plates. In case if it travels superiorly, it can even go up to the floor of the nasal fossa, maxillary sinus, or also invade into the cortical lining of your mandibular canal. Loss of lamina dura is also another characteristic feature, and the most important thing is your floating in space appearance, especially of the teeth, because of the massive destruction of the bone around that affected area. Moth-eaten appearance and floating in space appearance are the two pathognomic radiographic features of oral cancer. However, if the tumor is benign, you will not be able to see any resorption of the roots. Otherwise, resorption of the roots will also be visible. Now, advanced imaging modalities such as CT, MRI, PET and all are actually indicated when you want to assess the size and extent of the tumor, especially in 3 dimensionals. MRI is more indicative when you want to see soft tissues like your intracranial invasion, and CT is best for assessment of bony involvement by the tumor mass. Now, in case of extensive metastasis, like you want to assess the involvement of the carotid artery, cranium, parapharyngeal spaces, etc., CECT, which is contrast enhanced CT or contrast enhanced MRI, is what is basically indicated. To assess lymph node metastasis, you can always do or indicate the patient for a CT MRI guided FNAC. PET is indicated when you want to check for any metastasis, full body metastasis, recurrence, and especially for the metabolic activity of the tumor to assess for that. Now, distance metastasis can be done by chest radiography or by abdominal ultrasonography, radionuclide imaging, as well as blood studies for your tumor markers. The tumor markers database is increasing day by day, so you can always have tumor markers to find out if there's any distant metastasis or not. Now, moving on to the clinical investigative procedures, beginning with the most simplest one is your vital staining. So vital staining basically aids in your early detection of your oral precancerous and malignant lesion. So it is basically indicated right in the stage of your precancerous stage. However, always keep it in mind that it is not cancer specific, right? So the two vital staining techniques that I'll be discussing about right now is basically your Lugol's iodine and your Toldin blue staining. Lugol's iron, basically the stain reacts with the cell glycogen, creating a brown-black stain. And this staining is basically inversely related to your degree of keratosis. So like you can see in this area, there's a thick band of leukoplakia or some other precancerous lesion, which has actually not taken up much of the stain. So the other normal mucosa seems to have taken much of the stain. So the area where much of the stain has not been uptaken is indicative of undergoing further investigation like your biopsy. Toldum blue staining is also very commonly used. The stain basically stains, like the toldum blue basically stains your altered mitochondrial DNA. And all of you know, dysplastic cells have got a larger, relatively increased amount of DNA. So wherever there's any sort of dysplasia or pre-dysplastic changes, those areas will uptake the stain and give off a bright blue color, in which you can actually determine the appropriate site for biopsy, especially if it is a very large lesion. Now, the technique, I've just given it in brief right now here. The patient is basically asked to rinse the mouth to remove any food debris. Then the patient is asked to rinse with 1% of acetic acid, and the mucosa is dried with gauze. And then we apply 1% toldum blue solution onto the suspected area. After 5 minutes, we again ask the patient to rinse with any acetic acid to remove off any remnant stains. And wherever the stains remain, the areas which has got still uptaken the stain, that is the area from where the biopsy or the further investigations should be done. Now, the next thing that you can also do is exfoliative cytology. Again, it's painless and it's bloodless. It helps in assessing any dysplastic or cancerous cell. The principle behind this is your dysplastic or cancerous cells have got very weaker connections among each other as well as to your surrounding tissue. So these cells easily tend to slough off on just slight provocation itself. So you can actually collect all these dysplastic or cancerous cells using a tongue blade or a Siemens spatula, apply it onto a microscopic slide, dry it, and then you can stain it, and you can always examine the features under the microscope. So these are indicated when you need rapid laboratory evaluation and confirmation of any malignancy, especially by your Papanicolaou stained smear. Then you can also evaluate suspicious pre-malignant lesion, especially when the patient is in fear of a biopsy, especially bloodless, the patient has a phobia of blood or pain. This is always the best initial stage that you can do, so that you can tell the patient that you are in the stage of where you have to undergo a definitive further investigative procedure. Cytology is always an adjunct to biopsy, especially in cases where you have got multiple pre-malignant lesions throughout the oral cavity. Also, you can always check out any recurrence in that previously treated area which has been previously treated with excision or radiation. You can always evaluate that area much more easier, rapidly using an exfoliative cytology. Not just for pre-malignancy and precancerous lesions, you can also examine the changes in the buccal mucosa and various anemias. You can evaluate non-keratinized red patches, ulcerative or vesicular lesions of oral mucosa very painlessly and bloodlessly using your exfoliative cytology. So this is just a diagrammatic representation of how you do an exfoliative cytology, and always keep it in mind, you get only the superficial cells as a specimen for examination. You do not get any information about your intermediate or your basal cell layers. So what are the advantages? Like I've already told you, quick, simple, painless, non-invasive, it's bloodless, it's safe, it's absolutely inexpensive, because you're just going to use a tongue blade or a Siemens spatula, and it requires no anesthesia. You can always help check against false negative biopsy. That is, a negative has come in the biopsy, but if you see a positive in your exfoliative cytology, you have to send the patient back for a rebiopsy. And it is useful in screening for recurrent carcinoma and for lesions whose appearance does not warrant your biopsy, but still you're suspicious and you want to rule out any sort of, you don't want to keep any doubt impending. However, the disadvantages, it can give you a lot of false negative, because I told you that only the superficial layer is being examined. So you do not get any information about the deeper layers, especially because of inadequate sampling. That's what I told you. Underneath layers are not examined. Now, moving on, the other better way of doing an exfoliative biopsy is basically a brush biopsy. It's a substitute for your conventional exfoliative cytology. In this, nothing. It basically uses a brush, and in that, once you place it on the patient's suspected lesion, you basically are able to get a biopsy specimen which has got all the three layers, that is both your basal, intermediate as well as your superficial layer. This again does not require topical or local anesthetic, and it causes little, just very little bleeding as well as pain, which can be tolerated by the patient. The commercially available kit that is used for brush biopsy is your oral CDX, and the procedure is basically nothing that you have to place. Like you can see in this picture, you just have to place the brush onto the side, rotate it till you are able to see pinpoint bleeding. Once you see that, remove the brush, transfer that specimen onto the slide and fix it. And then you basically, that sample is screened by a computer equipped with neural network based imaging processing system, which can actually detect any oral precancerous or cancerous cells. However, end of the day, despite it being completely digitalized, you should have a final review by the pathologist always. And in case it's still inconclusive, definitely the patient has to be subjected to for scalpel biopsy. This is a pictorial representation, just like I showed for your brush, your exfoliative cytology. Brush biopsy gives you a complete transepithelial specimen having all your superficial, intermediate as well as your basal layers. And the results of this brush biopsy specimen usually comes in the form of inadequate, whether if it's like if the specimen is inadequate or negative, that there is, you cannot see any abnormality. If there is atypical, that is, there is some sort of abnormal changes, but it's not of a certain diagnostic significance. And positive when you are actually, when the specimen has actually positive dysplastic or malignant cells. Okay, so this atypical and positive is when the patient has to undergo a scalpel biopsy. So speaking of biopsy, what is biopsy? Biopsy is nothing but removal of tissue from a living organism for the purpose of microscopic examination and diagnosis. And it is indicated especially for confirmatory diagnosis of pathological lesions, determining whether the lesion is neoplastic or non-neoplastic, for grading of malignant tumors, because that, depending upon that grading, is how your treatment plan is basically devised. Okay, diagnosis of metastatic lesions as well as evaluation of any recurrence. Now, there are different types of biopsies. There are almost 7 types, where you have got fine needle biopsy like this. You can see in this picture where a needle is penetrated into the tumor, and then you are able to, take out the specimen and put it onto a slide and examine. You have got curettage, you have got excisional biopsy, you have got incisional biopsy. This is a picture of a punch biopsy. This is a picture of a trephine biopsy, which is basically nothing but bone marrow biopsy. And then finally, you have got about frozen section biopsy. So moving on to the most commonly used biopsies in intraoral cavity, the first one is your excisional biopsy. The term itself tells you everything. Basically, it's a complete excision of the lesion. So this is usually indicated in smaller lesions. It can be usually done for a part of a therapy. That is, if you excise the entire lesion, it is therapeutic. Otherwise, you can always do excisional biopsy as a part of your diagnostic procedure also. However, like you see in this picture, whenever you take the lesion, always make sure a bit amount of normal tissue is also taken and then only sutured, so that there is always comparison between your pathological or your suspected malignant lesion and your normal tissue. Moving on to incisional biopsy. Incisional biopsy is basically nothing but removal of a wedge-shaped specimen which contains the pathological tissue along with surrounding normal tissue. This is usually indicated when the pathology is really large, okay, and or it is multiple. You cannot literally excise the entire buccal mucosa when the patient has got a large leukoplakic lesion. So that's when you indicate the patient for an incisive biopsy. So moving on to punch biopsy. Punch biopsy is also indicated in cases where there's a heavy leukoplakic lesion, in which, like I showed you in the earlier picture, a punch is inserted, twisted, and then pulled out, and then that remaining tissue is just cut off. It actually, the surgical defect is really small, so it doesn't require much suturing, and this is much more convenient for the patient. Frozen section biopsy is done usually during surgeries, especially towards the end of surgery, to make sure there is a clearance of the margins. So it is done immediately, and the only disadvantage of this is you do not have slide preservation like your previous other types of biopsies. You cannot examine these slides for future use because all these are basically in frozen sections. Here there's nothing but I'll tell you how you do a frozen section biopsy. The excised tissue specimen is first frozen in a deep freezer, and then that frozen section is basically section and stained, and you are able to report it, in which within maybe a span of, like 10 minutes, you will get a report ready hand. So surgeons actually towards the end, before they're closing the wound, they always send the specimen, the edge of the normal tissue for a frozen section biopsy, just to ascertain that none of the malignancy is left behind. So you can see the specimen is basically frozen and thin layers are actually taken and then studied under the microscope. So invariably, all your biopsies at the end of the day will give you 3 types of histological reports, whether it's a well-differentiated squamous cell carcinoma, whether it's a moderately differentiated squamous cell carcinoma, or whether it's a poorly differentiated squamous cell carcinoma. Depending upon the histological grading as well as the TNM staging, that's how the surgeons, the radiotherapists, as well as your chemotherapy doctors all decide upon the further progress of the patient's therapy. Now, moving on to the advanced techniques, though I mentioned quite a lot of advanced techniques in the initial slide, I'll be emphasizing mainly basically on 2 techniques, which is your well scope as well as your VC light. So VC light is nothing but a non-toxic chemiluminescent light. The word itself has got light. So it's basically nothing but showing a non-toxic chemiluminescent light into the mouth in such a way that depending upon the differential property of the abnormal tissue, that is your suspected dysplastic or malignant tissue, and your normal tissue, they glow differently under this chemiluminescent light. So this is a picture of your VC light kit, and the components are basically nothing but your VC light rinse, which is 1% acetic acid solution. You have a VC light capsule, which is a chemiluminescent light stick. You have got a VC light retractor with sheath and handle, basically to retract the oral cavity. In this, it's almost the same thing. You ask the patient to rinse the mouth to remove any food debris, and you ask the patient to have rinse the mouth with the VC light rinse, and then you activate the chemiluminescent light stick and you shine it into the patient's mouth like this picture, and whichever area is abnormal, that area actually gives you a higher glow than compared to your normal areas. So the principle of action, like I mentioned over here, is normal epithelium is able to absorb the VC light. That is basically your chemiluminescent light, and it will still appear dark. However, your abnormal epithelium, because it has got dysplastic cells over there, that is, if your suspected lesion has got dysplastic cells, definitely one of the features of dysplastic cell is an enlarged nucleus, right? Your nucleus cytoplasmic ratio is actually different. So your nucleus is really large as compared to your cytoplasm. So because of that enlarged nucleus, it is able to reflect the VC light, and those areas where there is any sort of dysplasia, that areas will appear bright, and that is the area which is supposed to be furtherly subjected to further investigations like your biopsy. Kindly keep in mind, biopsy is ultimately your gold standard for investigation in your oral cancer. Said and done about all your advanced techniques, once you find out any suspected area, before the patient is being subjected to whatever dose of radiation, chemotherapy or surgery, always a biopsy has to be done to give a final histopathological grading before the patient is actually subjected to various modalities of treatment. So like you can see in this picture, when the VC light is being shown, the normal tissues will actually absorb the light and there's no reflection. But wherever the dysplastic, whether it is really deep or whether it's really superficial, till whatever extent the VC light is able to penetrate, it will show you those areas appear white. So these areas actually warrant further investigation. The next thing which I wanted to speak about is your well scope. So well scope is based on direct visualization of your tissue fluorescence. That is on the basis of the principle of the tissue's normal fluorescence capability. It is basically using that property. So here, Whale scope handpiece will basically emit a safe blue light into the oral cavity, which will actually cause tissue fluorescence. Now, these optical filters in the Whale scope handpiece will actually be able to help the clinician view the different fluorescence signature. That is, if it's a normal tissue, what is the fluorescence? If it's an abnormal tissue, what is the fluorescence? You have special optical filters within the Whale scope, which will actually give you the indication of which area is actually kind of suspicious and which warrants further definitive investigation. So this is a picture of your whale scope, which actually gives you a blue safe light. So you can see, as like in this picture, in the areas of abnormality, that where you have any sort of dysplastic cells or any abnormal epithelial cells, where there's disruption of your stromal collagen, etc., that area you will not be able to see much of fluorescence. Okay, so that area will actually kind of appear really kind of dark. But however, your normal tissue will actually show a lot of fluorescence under this safe lighting. So whatever we said in VisiLight, it's a total opposite in whale scope. The areas which is suspicious basically appear dark, and the areas which is normal will appear much more brighter. So finally, to conclude, there are much more actually investigative procedures, but for the sake of academics, I have shortened off to what is more important, because in your day-to-day practice, these will be one of these modalities will definitely be very handy for you, and it will be easily available for you. Why? Because these higher rates of mortality and morbidity, to close that gap of the high mortality, morbidity, and the diagnosis, it is imperative that every dentist should be familiarized not only with the initial signs and symptoms of the patients, but you should at least be in a position to at least do any one modality, investigative modality in your setup, and then only further refer the patient to a higher treatment center, so that you can actually tell the patient that the report shows that there is some sort of suspicion which you have to undergo. If you just tell the patient by the word of the mouth, sometimes they do not take it very seriously. So if you do an investigation where there is a report saying strong suspicion of malignancy, it will actually push the patient to further go in for further investigation. Thus, that will actually help in early referral to the specialty center, and the treatment process will hasten, which can actually reduce the disfigurement. You should always remember, surgery, radiation, all comes with disfigurement, because that's basically your head and neck region. So it causes a lot of psychological trauma also to the patient. So hastening the treatment process at the very early stages can actually reduce the disfigurement as a resultant of the treatment of oral cancer. So I hope I've made myself very clear and how important this topic is to you, not just in academic point of view, but also in your day-to-day practice. Thank you.